So thanks for coming today, guys. This lecture, actually the next couple of lectures are something that Wendy and I met and talked about. It's been a few years since we last kind of went over what HIPAA, EMTLA, and DNR mean to me as the medical director. Um, so we're going to go over that. We're also going to go over some documentation stuff, including, how to better document refusals, etc. So, with that being said, let's get to it. So today we're going to talk about HIPAA, some specific HIPAA situations, along with EMTLA and some EMTLA situations, and then DNR specifically as it pertains to Ohio, since Ohio's DNR system is frankly a mess. So one of the things that really drew me to emergency medicine in the first place was the fact that anybody who came to the door was going to get healthcare. They were going to get taken care of. They were going to get seen by a doctor. They were going to get whatever treatment that they needed to, make them at least stable again. And that was one of the things that I liked about it. And yeah, this is a political cartoon from all the way back in 2011. But it it brought up something. This was something that one of the presidential candidates had said during that cycle was, we kind of already have universal health care. It's called the emergency department. And I know that was supposed to be a dig at, Obamacare and things like that. But the reality is that, that's what one of the things that drew me to emergency medicine. And I think that's what draws a lot of us in emergency medicine to it, is the fact that, I don't really have to worry about prior authorizations. I don't have to worry about whether or not, this person is going to get declined for, their study, whether it be a CAT scan or an ultrasound or whatnot. Because of EMTLA, I can just get what I need, and kind of let the finances sort themselves out on the back end. Now, the problem is for the patient, on the back end, sometimes that has consequences, which is why we still need, healthcare reform and a better way of doing things. But, in the heat of the moment, it's nice to be able to just focus on taking care of the patient, etc. So let's talk a little bit about HIPAA first. So HIPAA was the Health Insurance Portability and Accountability Act, and it was signed into place a couple of decades ago. And for the first time ever, the feds standardized what was considered to be protected health information. It also standardized how we go about sharing information amongst entities, whether that be between doctors, between hospitals, between the hospital and the insurance company, etc. It also began assessing fines and such for those that were violating the law. It also put into place insurance company reporting requirements. So the insurance companies had to report how they're using your protected health information, who's had access to it, that kinds of thing. It also, for the first time ever, gave, everyone on a federal level specific rights to their health information. Prior to this, there really wasn't anything at the federal level that said that your health information is actually yours. Prior to this, it was widely accepted that all the documentation, et cetera, all the lab results, things like that, weren't actually owned by you, that they were owned by whoever held the records. And this, for the first time, said that no, they're just the custodians of those records, but that you actually have a right to be able to see whatever is in your healthcare record, with certain caveats, of course. But that this was your property and they were just the custodians of it. So really what it comes down to when it comes to HIPAA is that we can't tell others about patients and their results, et cetera, or even that we interacted with them unless it is pertinent to, their healthcare. There are some limited circumstances where we are required to report what we find, such as, cases of child abuse or elderly abuse. And then in, I believe, all 50 states, gunshot wounds are a mandatory report. In many states, stabbings and dog bites are mandatory reports as well. So in those circumstances, it's on someone to report that to the appropriate authority. Obviously, if the patient is an imminent threat to themselves or to other folks, that means that we need to report that, in our case, typically to law enforcement, or if we, have a statement like that said while we're already transporting the patient, then to the hospital, because there are certain things that have to happen in that situation. Certain states require reporting of specific diseases, such as, currently COVID is a mandatory report in most states. Syphilis, hepatitis, measles, mumps, rubella, HIV, TB, those are the kinds of things. And that's typically on the hospital because we're the ones who are testing for it. We're the ones who are making the diagnosis of it. And so when we make that diagnosis, we have to file a report, typically electronically, with the Department of Public Health, who then can follow up on it if anything is needed. If it's a sexual partner, they have to be notified. If this is something where we need to begin vaccinating people surrounding, a measles outbreak, et cetera, then the public health agencies can begin to work on doing that. When you disclose because of these circumstances, et cetera, that is carved out of HIPAA, and so you're not violating HIPAA when you're providing a mandatory report. Other important aspects of HIPAA are that you're only allowed to access the information required to do your job. So, for instance, an X-ray tech at the hospital would have no reason to access whether or not somebody had, an HIV test 5 years ago, unless they had been themselves involved in a needle stick or something like that. And so you can't go back if it's not pertinent to your job and just rifle through a patient's records just because they happen to be there. You really are only allowed to access the information that is required for you to do your job. You've also got to have a unique password for your system, and you should not share your login information with anyone. That's one of the things that it has been really important with the proliferation of EPCRs like ESO. Many departments, will sometimes share login information, et cetera, that's not specific to the person, but is specific to the truck. And that's really not actually allowed under HIPAA. If you're aware of any sort of breach in confidentiality, even if it's yourself, you have to report it, because somebody needs to follow through on that, and it's typically the privacy officer for the department. So that way the patient can get notified, we can seal the breach, determine exactly what it was that was disclosed and what the ramifications are of that. The good news is that ESO logs all of our access to the record. So if we log in and look at a patient's record, it's logging that. If we change something in that record, it's logging it. If we try and delete something, it's logging all of that information. So it's taking care of a lot of the back end stuff for us automatically. Inappropriate sharing of information is a violation of both state and federal laws, and the penalties can be pretty significant. So please keep that in mind. So what's considered to be protected? It's anything that directly or indirectly identifies a person, such as their name, social security number, driver's license number, insurance information. In our situation, it also applies to the run numbers. And the reason for that is because that run number is actually assigned by Hamilton County 911. And so as a result, that run number can then be tied back outside of ESO to a patient's address, potentially their name, etc. It may apply to any other information that can be reasonably tied back to a patient. So, basically everything is considered protected health information. And so it's better to not disclose, anything. Information can be de-identified prior to being released, but the privacy officer must verify any of its removal, such as, we have a house explosion with multiple patients injured, et cetera. We, in situations like that, typically won't directly identify the address, but we'll say in the X block of, Main Street, in a lot of these press releases, because then we're sort of limiting the exposure of whose house it was exactly that patients were taken out of. So who can get protected health information? Well, it's anyone that's involved in the treatment of a patient. And the funny thing is this comes up more often on interfacility transfers. I've had many floor nurses refuse to give even report or the patient's name or anything like that to the paramedics that show up to take somebody, from say their hospital to an extended care facility, et cetera, because they say that they can't even give out the patient's name, um, because that's protected health information. Well, clearly we're there to pick the patient up and take them to a nursing home, and so we are part of their care team. That's pertinent information for us. We need to know about why they were hospitalized, how long they've been hospitalized, what meds they're currently on, things like that, because if this patient deteriorates while we're transporting them, that could pose problems. Anybody that's involved in processing the payments is also considered to be, bound by HIPAA, because this information is being used to bill insurance. Anybody that's involved in healthcare operations, meaning, the folks that are determining, how many 4x4s we need to order, or whether or not we need to have additional staff on overnight because these patients are sicker. Anything outside of that requires written authorization. So the patients will typically have to fill out a release of records, et cetera, that spells out what their rights are, what our responsibilities are to protect that information, what information is going to be released, et cetera. When you're doing your job is to only disclose the minimum necessary information. So if again, if we're at the hospital and have to mandatorily report something, we will only release the information that is pertinent to that report. So we will say that, X patient is here with a gunshot wound, but we don't have to go into what their sexual orientation is, their history, necessarily what meds they're on, et cetera, unless it's pertinent to the criminal investigation. So we only disclose the minimum necessary information to meet whatever requirement that is, or to safely transition care over to, the next person. So the penalties can be pretty significant. There's possible termination of employment, civil penalties of up to $1.5 million per year per violation. So that what that means is that, if a hospital system has 300,000 patients that get exposed to, the internet, that's $1.5 million, times 300,000 times however long that information was out on the internet. So it can add up really, really quickly. There's also possible criminal penalties of up to $250,000 and possible imprisonment for up to 10 years, if you do this, knowingly, etc. Additionally, the patient themselves can then sue you in private action for invasion of privacy, negligence, and any other consequences that come from this. And so the dollar amounts, add up really, really quickly. So it's really not worth taking that risk, on potentially releasing this information. All right, let's transition a little bit towards EMTLA. So EMTLA stands for the Emergency Medical Treatment and Active Labor Act. It was signed into law in 1986. It's so-called the anti-dumping law. And this came about because of a series of unfortunate events. What happened was back in the early 80s, primarily Chicago was having some issues with hospitals and the indigent population. And what would happen is, patients would show up to private healthcare facilities to seek care. And those private facilities did not receive any public dollars. They would see that the patient was uninsured, and instead of stabilizing them, caring for them, etc., would quite literally put them in a taxi and take them across town to one of the publicly funded hospitals, and literally drop them off there. And so put this burden for taking care of the indigent on just the publicly funded hospitals. As you can imagine, because some of these patients were rather sick, some patients died in the back of taxi cabs because they hadn't been provided any stabilizing treatment prior to being basically put in the back of a taxi. There were a couple of kids that died as a result of this, including newborns, because actively laboring mothers would show up to these private hospitals and again be put in the back of a taxi cab and would deliver in the back of a cab rather than in a healthcare facility. And so after all this began happening, the feds got involved and passed this law. Interestingly, the way they did this was through the Centers for Medicare and Medicaid Services, which is about 30% of healthcare funding in most states. So it only applies to hospitals that participate in Medicare. That ends up being the vast majority of hospitals in the United States because they are such a big section of the healthcare population, about 30%. However, it's unfunded, meaning that all the care that's provided to these folks that don't have insurance or any care that's provided under EMTLA is not funded. And so, if you have somebody that's uninsured, having a heart attack, et cetera, they can show up to a hospital, and our responsibility at the hospital is to stabilize them within our capabilities. And if that means they need open heart surgery to fix their STEMI, that means they're getting open heart surgery, and we have to do that. Again, I think that's a good thing. We're taking care of the patient, et cetera. I really wish that we would find a different way of doing it, though. As a result, what happens is those costs have to be paid for somehow. And so all the rest of us that are insured, whether it's through Medicare or through private insurance, end up, having to subsidize that care indirectly. So there's a reason that aspirin tablet, that you get at the hospital is suddenly $7 when it's less than a penny on the wholesale market. And it's because they have to make up for all this unfunded care that they're mandated to provide. So there's a couple of definitions that we have to go over that are in the law, and emergency medical condition is one of the most important ones. And it basically says that anytime somebody thinks that they are having an emergency because of severe pain, or that they're concerned about this potentially harming them, et cetera, that's considered to be an emergency medical condition. There's a statement that has been ruled on in the past called the prudent layperson standard, which means that when we're making decisions about whether something is an emergency medical condition, we're not relying on, say a guy like me, a board certified emergency medicine physician who's been in practice for 10 years plus, to determine whether or not that's an emergency medical condition at the time. We're relying on somebody with minimal, healthcare literacy and knowledge to decide whether or not that sore throat really is an emergency medical condition. So that's why many hospital systems, if you show up, we are going to take care of you. We're going to treat you and figure out what's going on with you within our capabilities, and ensure that no emergency medical condition, is actually present. And that's only able to be done through the next definition, which is through emergency departments and through qualified medical examiners. So an emergency department is any area of the hospital that's equipped and staffed and used a significant portion of the time for the initial evaluation and treatment of outpatients for emergency medical conditions. And so that can extend outside of the traditional emergency department. For example, psychiatric emergency services at UC, even though that's not the full emergency department, that is considered an extension of the emergency department. The same thing applies to many bigger hospitals that have separate labor and delivery triage areas. So when we are asked to take, a 32-weeker who is laboring, et cetera, up to the labor and delivery floor and bypass the emergency department, that's okay. The hospital has policies in place that say that that triage area, et cetera, is an extension of that emergency department. And so they're not violating EMTLA. We're not violating EMTLA by taking that patient, up to the labor and delivery floor so they can be assessed in that specialty area. Medical screening examination is another important aspect of this. And that's when a qualified medical examiner determines whether or not an emergency medical condition that you believe you have actually is existing. And if there is an emergency medical condition, then we've got to provide that necessary treatment and stabilizing care within our capabilities. A qualified examiner is generally accepted to mean a physician or an advanced practice provider, such as a physician's assistant, a nurse practitioner, a certified nurse midwife. There are some states that have expanded that to include more highly trained registered nurses. But in general, most places have defined that as physicians or advanced practice providers. So when someone shows up to the emergency department with what they believe to be is an emergency medical condition, the hospital has to provide this medical screening examination by a qualified examiner. We can't delay care to inquire about payment or insurance coverage. We've also got to post a sign that notifies patients of their specific rights when it comes to their treatment, which is why you'll see frequently in the waiting rooms of most hospitals, Medicare rights, et cetera, spelled out. If an emergency medical condition exists after that medical examination, that medical screening examination, the hospital has to provide treatment until the condition is resolved or stabilized, or must provide for an appropriate transfer, meaning that we send them to some place that does have the capabilities of stabilizing that. Hospitals that have those higher level capabilities, such as trauma centers, stroke centers, cath labs, et cetera, must accept transfer from hospitals that don't have those capabilities. However, if a hospital with higher capacity or higher capability doesn't have any open beds, or they don't have the capability of taking care of that condition because, they're already tied up with too many cases of a similar like, that doctor is not on call that weekend, that kind of thing, et cetera, then the tertiary care facility is not obligated to take that patient and transfer. So that's one of the problems that has come up very frequently throughout COVID has been, we've got these sick patients that are at lower capability hospitals that we're trying to get to higher capability hospitals, even if it's not related to COVID. But because of COVID, there were no beds or there were no ventilators to take care of that patient. And so as a result, we had patients that, had other non-COVID related medical problems, et cetera, have worse outcomes and some die just simply because the other facilities were too overwhelmed to safely care for them. And so they would sit at their original facility, sometimes for days, or I've seen as long as a week. I remember a few years ago in the heat of COVID, I literally called every hospital in Greater Cincinnati, Dayton, Columbus. I even called Louisville and Lexington. And we were at the end of my shift getting ready to start calling hospitals in Indiana as well, trying to find some place that could care for this patient I had out at one of our smaller facilities. So, it gets really sticky fast. So, yeah, it sometimes can be nice to just basically dump and run. But we also need to think about the downstream consequences of, where we take patients. This is why it's really important, especially lately, to make sure that you're taking the patient to the right place. We as a department, I think, do a really good job, and we're also blessed to have our choice of multiple different facilities. Our more rural partners, unfortunately, lots of the time have a choice or have two choices, and they may not have that specialty level care. And so sometimes that means that patient, even though the EMS crew knows that they need to go to a higher level of care, et cetera, may end up taking them to the lower level of care first, with the expectation that that patient can then get transferred down the road. Pre-COVID, we typically could do that. Since COVID, though, it's become harder and harder and harder for us to facilitate transfers among hospitals because everybody's running at such high capacity. That's been especially prevalent for several years now when it comes to psychiatric care, where all the psychiatric beds may be, completely full. And so as a result, psych patients may sit at a non-psych facility sometimes for weeks, or if you're out west, I know of patients that are sitting out there for a month or more until an inpatient psychiatric bed opens up. So in order for a hospital to transfer someone, we've got to stabilize that patient. But that means that that patient has been stabilized such that the person transferring them says that there's no real significant deterioration that will occur during that transfer. Or the patient is still considered to be unstable, but that the medical benefits of the transfer outweigh the risks of it. Say, for instance, I have a kid or a mom out at Mercy Claremont that does not have OBGYN capabilities. And we've got a kid who is stuck, where we've tried everything. We're not going to be able to deliver this kid. It may mean that, yeah, there's risk with transferring, but we're not going to be able to fix this. We need to send you actively laboring with a stuck kid down the road to a facility that can do a C-section to potentially save everybody's life. Patients are also able to make a transfer request in writing to go someplace after we inform them of the hospital's obligations under EMTLA. So this sometimes comes up, at especially like heart patients, et cetera. We'll take a patient to the closest hospital if they're having chest pain, et cetera, work them up, determine that they're not having a heart attack, et cetera. But then they'll want to go to a different facility where their cardiologist is so they can get the additional inpatient workup that's needed. And we will very often, have no problem transferring that patient to their choice destination. We just have to inform them that, we're capable of taking care of this, that this is you initiating the transfer, that we've offered to keep you here, et cetera, and you still want to go. As long as we've informed the patient of that, then and they still choose to go, then that's totally fine. So as far as stabilization goes, the hospitals have to stabilize within our capabilities. So that does not mean that suddenly Dr. Charlton is going to be able to start doing appendectomies just because I saw a couple on YouTube. We really have to, only do things within our capabilities. We've got to provide copies of the medical record to the receiving hospital. That's really easy here locally because everybody is on Epic except for the VA. And so literally they can just open up Care Everywhere and, see real time our records. The hospital that is sending the patient must confirm that the receiving hospital has the space and the qualified personnel to treat that condition. So we can't just say, oh yeah, we'll send you to Christ and not call Christ. We have to call Christ, and Christ has to say, yes, please send the person. The doc who's going to be receiving that patient also has to say, yep, I can take care of that. Yes, please send the person. The hospital that is sending also has to ensure that the way that we're sending the person is appropriate. So for example, it would be ill-advised for us to send somebody on a ventilator via basic life support ambulance to a different intensive care unit. That's not something that would be okay within EMTLA. So the consequences of this can be pretty significant. Not only is there the liability of, something happening, on the way or as a result of the transfer, but if somebody is inappropriately transferring or inappropriately refuses a transfer, it's a $50,000 per violation fine to the hospital and a $50,000 per violation fine to the physician. That's also not paid for by liability insurance. It also can place both the hospital and the physician's Medicare and Medicaid status in jeopardy. And if that happens, that means that those people could be suspended or barred from participating in Medicare or Medicaid. As I said, Medicare alone in most states makes up 30% or more of the payer mix. And so all of a sudden, if a third of your patients disappear overnight, that's probably going to put you out of business, or at the very least, significantly curtail what you're able to do. So has real big consequences for the hospitals. There's also lawsuits that can happen. Not only can the patient sue you, but the receiving hospital can sue for damages as a consequence of an inappropriate transfer, including the costs of taking care of that patient that you should have been able to take care of in the first place. So what EMTLA does not require is for us to provide treatment for a non-emergency medical condition, provide treatment beyond our hospitals or physicians' capabilities, beyond the scope of practice or standard of care. So we don't have to provide, crackpot medicine or experimental therapies or, things like that, because those are not yet the standard of care. It also does not require for the treatment and stabilization of non-emergency patients. So if you're at a facility and, have some sort of surgical complication, as a result of your gallbladder surgery, et cetera, there's actually technically no EMTLA requirement that another facility accept that patient and transfer because they were not there for an emergency medical condition. Now, granted, hospitals are going to do the right thing. They're going to take care of stuff like that, but there's actually no federal implication under EMTLA. Any request for non-emergency care is also not required, such as immunizations, blood pressure checks, health screening, and treatment after EMTLA no longer applies is after the patient has been stabilized or the patient arrives at the other facility. So in those situations, we've met our obligations. Everything is good. EMTLA no longer applies. All right, let's talk quickly about DNR. As you guys are all well aware, DNR in the state of Ohio can be very confusing. There are two levels of DNR spelled out in state law. There's DNR comfort care, and then there's DNR comfort care arrest. DNR comfort care kicks in as soon as it is signed. That means that from this moment forward, I only want to be provided the things that are outlined in law for this level of care. DNR comfort care arrest means I want everything done up until the point that either my breathing stops or my heart stops. Once that occurs, I only want things provided within the DNR comfort care framework. So do everything up until the point that my breathing or my heart stops, but at that point, I only want to be kept comfortable. So what's allowed under the DNR is airway suctioning, oxygen administration, positioning for comfort, splinting or immobilization, bleeding control, pain management, emotional support. We're specifically not allowed when this comfort care category has been activated to do CPR or chest compressions, to insert an artificial airway, administer resuscitative drugs such as epinephrine, amiodarone, things like that. We're not allowed to defibrillate or cardiovert, provide respiratory assistance, meaning bag valve mask ventilation. An interesting thing is most of us have accepted that CPAP or BiPAP can be used if the intent of it is for comfort. That feeling of suffocation, etc., is really uncomfortable. And yes, we've got medications that can help with that. But CPAP is generally considered to be a comfort measure, as long as that's what we're doing it for. We're not titrating this up, etc., trying to get their blood gases significantly improved. We're not allowed to initiate a resuscitative IV. So if we've got somebody who is hypotensive, etc., we're not allowed to flood them with, the 30 cc's per kg of fluid, etc., willy-nilly. But if somebody is, slightly dehydrated, etc., and we need to provide them some IV fluids because of their dehydration, and with the intent of it to make them more comfortable, then we're allowed to do that. We're also not allowed to initiate cardiac monitoring because, frankly, who really cares what their underlying rhythm is? We're not allowed to treat whatever that underlying rhythm is anyway, so why put them on cardiac monitoring? So what happens if we started doing stuff, um, and then somebody produces the DNR paperwork? So we've got to verify their DNR status. So make sure that this paperwork is actually signed and is actually valid, and has been filled out properly. Then we are allowed to discontinue any of the will not interventions. However, if somebody is already on some sort of a treatment that was ongoing prior to your arrival as EMS, then you're not expected to discontinue those. So, if we show up to somebody who is on a ventilator, et cetera, at baseline, and somebody produces the DNR, we are not expected to take them off of the ventilator. If we put them on the ventilator, then yes, we can take them off of the ventilator that we put them on. But somebody that has a PICC line infusing, or has a ventilator, et cetera, we're not in the business of disconnecting people from equipment that we did not start them on. So we don't have any obligation under that. But what if the family says, I want everything done? Well, there's some different things that are involved. Patients that have signed their own DNR can revoke their own DNR, and they're the only ones who can revoke their own DNR. So even if a power of attorney swoops in at the last minute and says, I don't care that mom signed that 3 months ago, I'm her power of attorney now, I'm overriding that. They're not actually allowed to do that. If the patient themselves signed the DNR, the patient is the only person who can revoke that DNR. However, if a power of attorney signed the DNR, the power of attorney can revoke that DNR, or the patient can revoke that DNR. A prime example is, you have somebody who has been incapacitated, they're not expected to live, et cetera. The power of attorney signs a DNR, and says, mom wouldn't want everything done. Mom rallies and gets better and now has capacity to make her own decisions again. Mom can revoke that DNR that whoever it was signed on their behalf. And that's totally fine. Family, bystanders, et cetera, cannot revoke a DNR if the patient signed it. So even though the patient's family may be saying, well, I'm going to sue you, et cetera, you have to resuscitate my mom, I don't care what my mom said, et cetera, you're actually immune from civil and criminal liability in this circumstance, because you are following the patient's wishes, and it's well spelled out within law that only the patient can revoke their own DNR. In these situations, all of us get it. These are sticky. There's a lot of legal implications with it, et cetera. The default really should be, continue providing whatever care it is that you think should be provided, and get medical control involved. Medical control can help take some of the liability off of you, can also help you guide this. We in the ER have to have these discussions sometimes numerous times a day, whereas you guys only have to do it periodically. So please let us help you kind of navigate this murky water that we have to get through sometimes. All right, so now we're going to play Cahoots. So I need everybody to, if you have the ability to, pull out your cell phone and scan this QR code, or go to kahoot.it. When you get to that website, it's going to ask you for a game pin. Don't put anything in that yet. I've got to generate that when I start the game. So we'll do that here in just a minute. So I'm going to give everybody, just a second to pull out their device of choice and go to this website so you can play along with the quiz. Okay, so here is that game pin. So put that game pin in, and it'll ask you to create a username. It can be whatever you want. The first time I ever played this, I did this game for, I think it was Springdale, and one of the younger guys had decided he was going to start growing a mustache, and so somebody decided to name themselves so and so's mustache because they love to harass the poor guy about it. So all right, I think that's probably going to be everybody for the time being. If you're still putting your stuff in, it's okay. This is all just for bragging rights anyway, so you'll still be able to join late. So this is just like at Buffalo Wild Wings, okay? The most correct answer in the shortest time frame gets the highest points, okay? So the faster you answer, the more points you get if you're right, okay? All right, law enforcement approaches you and asks if the patient is intoxicated. The best reply is... All right, so the correct answer is sorry, I can't talk about it. We can't say, yeah, he really smells of alcohol, because we're involved in that patient's care. And so we're not allowed to disclose information like that. We're not allowed to say, oh yeah, he's definitely, he's ataxic, he's slurring his words, stuff like that. What we can say is, sorry, I can't talk about it. However, you can subpoena the stuff. And it's a fairly straightforward process. The police officers know how to do this. They're just hoping to avoid some extra paperwork. And most of the time, the judge or the magistrate, whomever, will happily sign off on getting that record, etc., so that they can see, what you did, what the hospital did, etc., to get those lab results, and whatever else may be pertinent. So we're not allowed to say, yep, they look intoxicated, they smell intoxicated. Now, if the police officer hears the patient tell you that, oh yeah, I had 5 beers tonight and got behind the wheel, that's the patient disclosing on themselves. The patient said that, yes, it was being said to you, but the patient could see that a law enforcement officer was there and still chose to say whatever it was that they said. So, unfortunately, they've incriminated themselves. That was not a release on your part. Because intoxication is not a mandatory report, we're not obligated to tell law enforcement about it. And so as a result, we can't. All right, you just got a needle stick. Can the hospital tell you if the source is infected? This is kind of a trick question because we didn't go over it. So good. You guys were, for the most part, right. So yes, this type of thing is excluded from HIPAA. Obviously, the feds for once thought about us little people when they were creating this law. And so if a needle stick occurs, the hospital or whoever is investigating that can tell us about the source patient's status, whether they're HIV positive or not, whether they've got detectable virus, and things of that nature, because that impacts our decisions as healthcare providers on whether or not we're going to do, additional immunizations or accept prophylactic treatment, et cetera, to prevent, conversion into HIV positive ourselves, or, hepatitis B, et cetera. So they are allowed to tell us about those specific things. They're not allowed to tell us about, oh, and by the way, the person's also got, stage 4 melanoma cancer and it's matted to here and here and here. We're only allowed to know about the stuff pertinent to that needle stick. All right. A psych patient says they're going to kill their girlfriend when he gets home. What do we do? Good. So pretty much everybody got it right. You're obligated to report this to protect the girlfriend. Remember that with HIPAA, you have an obligation to report if somebody is a danger to themselves or a danger to others, meaning the suicidal patient or the homicidal patient, et cetera. We have to report to the appropriate authorities. Heartthrob is gaining ground. You are called for an injured person. It's a GSW to the leg. Can you report this? All right. Yes, it's required to be reported to the police. As much as I would love for us to be able to say no, because then you're tied up on scene forever, it really is required to be reported to the police. GSW is a mandatory report in all 50 states. So even if we get somebody dropped off at the hospital, EMS wasn't involved, we're still having to call the police to report that, because it's a crime has likely occurred, and this is specifically called out. Everybody's pretty much neck and neck. You are called to the hospital ED via cell phone by a patient. He wants to go to another hospital. What do you do? So, yes, I've had this actually happen to me before as a doc. It happens all the time at the hospitals where patients are not, getting the treatment that they wanted, or they have had some sort of a disagreement, etc. And so they call 911 from the ER, hoping for a different outcome. So the correct answer is no. Doing so would violate EMTLA. So because they are not going through the proper channels, etc., they cannot get a transfer independent of the hospital. Now, if the patient decides to discharge themselves by signing out against medical advice and goes out on the front apron and calls 911 from there, then, yes, the patient can do whatever they want. They can go where they and EMS want to take them, et cetera. But if they're still a patient within the hospital, no, taking them out of there would be a violation of EMTLA. All right, we've had a little bit of shifting in the leaderboard. About halfway through, a person collapsed at the medical office building attached to the hospital. Why did we get called? There's technically two answers for this. Good. So everybody got one of the two answers correct. So I would have accepted the hospital does not have an obligation to help this person, because they don't, but it was also because we have the equipment to get people safely to the ED. So an interesting carve out of HIPAA, or I'm sorry, of EMTLA, is medical office buildings, even if they are attached to the main hospital, are considered to be private physician offices and are not part of the hospital themselves. And so as a result, EMTLA does not apply there. Somebody who shows up to their private doctor's office, complaining of chest pain, EMTLA does not kick in until they present to the emergency department or to the hospital saying, hey, I'm here because I'm having chest pain. So technically the hospital doesn't have an obligation to help this person. But also, if you've ever walked around some of, especially the older medical office buildings, those hallways can be really narrow. There is no way we are getting a hospital gurney through some of them. And so a lot of the time we're calling because, the paramedics have the equipment to get people safely into the emergency department. Even if somebody gets into a crash in our front apron of the hospital because they're coming in for chest pain. If they get into a crash and are stuck in their car, we don't have extrication equipment. We're not going to be able to get them out of the car. And so that's why we would have to call 911 to have some help. The VA refused to take our patient when we showed up. How can they do that? So yes, this is, I'm at the VA in their emergency department and they're refusing to take my patient. How can they refuse to do that? We just went over this. So the feds have this unique ability to, whenever they write laws, they tend to exclude themselves from those same laws. That's why the military can get away with what it does and lots of federal things get done the way they are. So federal facilities are specifically excluded from EMTLA, including Indian Health Service, the VA, military hospitals, etc. So none of those are bound by EMTLA. So yes, you can be standing in the VA's emergency department and they can say, nope, we're not taking care of that. Put them back in the ambulance and take them somewhere else. And there's very little that can be done about it. You have a 30-week pregnant lady. Can you go directly to the OB floor? Yeah, so the correct answer is yes, as long as the facility has a policy about it. So as long as the facility says that, we're extending the emergency department to include the labor and delivery triage area, etc., then it's permitted. Now, that's not to say that you as an EMS service have an obligation to take them all the way up to the OB floor. That's different, but it is permitted under EMTLA. It does allow that to happen. You've got a bad trauma. Can you use the hospital's helipad? This is a bigger issue out in rural areas where you've got a non-trauma facility, but they've got a helipad. Can you go and use it? So this is an interesting carve out as well. Because you are, as an EMS service, bringing the patient to the helipad for the express purpose of taking them via a different type of EMS transport to a higher level of care, it's excluded. Now, if you run into the emergency department and say, hey, the helicopter's not here yet, I need some help out here. As soon as you do that, EMTLA kicks in. That means the hospital then has to provide the necessary stabilizing care and treatment and arrange for a transfer. The same happens if somebody from the hospital runs out to the ambulance and says, hey, you guys okay? Anything I can do? The moment that happens, EMTLA then applies. And so it can really delay the patient's care because now we've got to talk to the other hospital. The other hospital has to get the other doc on the line. The other doc has to say, sure, send the patient this way. If you just use the helipad, you're golden. But if anybody talks to the other party, you're sunk. EMTLA then applies. We have this happen periodically out at especially like Mount Orab, where we've got a nice helipad. It's got instrument flight rating for it, and so the local squads will call us to give us a heads up of, hey, we need to use your helipad. We'll turn on the landing lights, et cetera. And we also make darn sure to tell everybody, don't go out and gawk at the helicopter, because we could reasonably be considered to be accepting care of that patient when we do that. A patient is terminal, but the DNR paperwork isn't finished yet. The patient arrests. What should we do? Yeah, so there's technically two correct answers with this one. So we should resuscitate because we don't have DNR paperwork that says that we shouldn't resuscitate. But at the same time, we should also be calling medical control and explaining kind of the situation. And frequently when I encounter this, it's a matter of the DNR paperwork isn't filled out right, or they haven't been able to get into their doctor, or the hospice nurse is coming by tomorrow to, get them enrolled, things like that. Most of us in emergency medicine totally understand all of this. And as long as the story is good and, what you guys are telling us is that everybody on scene is saying, yeah, mom doesn't want this, we just haven't gotten the paperwork signed out, etc., then we will typically give you verbal orders to not resuscitate. That is totally fine. Just make sure you're documenting who you talk to, and the substance of that conversation. But most of us in emergency medicine are going to be totally fine if the story is good and there's no disagreement on scene about what to do. So start resuscitating, but at the same time, get out your speed dial. All right. Family says do everything, but there's a DNR. You should. So again, in this one, there's two correct answers. The correct answers are, provide comfort measures only, because that's what the DNR says. Okay. But at the same time, I would probably be calling medical control. Again, we have these discussions multiple times a day frequently and can help you guys navigate that. Sometimes it's, me getting on the phone with them and kind of explaining why we have to do things this way, that, we understand it. And very frequently when we, start discussing things in more detail, the heat of the moment has passed, etc., they come around and they realize that, yeah, this really is what mom would have wanted. Mom would not have wanted all this other stuff done, etc. I just was freaking out because, mom's dying in front of me. And so once we discuss things with them, etc., they tend to come around and be more reasonable. All right, last question. The family sues you because you didn't resuscitate. What happens next? Yeah, so the reality is that the vast majority of the time, these are not going to be brought to suit, period. And if they are brought to suit, a judge is going to toss the lawsuit very early on in the process because you're immune. You've got a signed valid DNR that you adhered to, etc. The fact that the family disagreed with that DNR is not a reason for it to be revoked. And so it's going to get tossed because you're immune. You followed the law. As a result, the law says You know, as long as you're following the law or believed that you were following the law, then you're immune from civil or criminal liability. It'll get tossed. Worst case, the two of us get deposed. But I've never heard of that happening in the state of Ohio because our immunity at baseline is so high, and then you add on to it DNR immunity, and you basically can't be found liable for anything. And so the likelihood that a judge isn't going to toss this right off the bat, you know, is very low. And so the likelihood that we would get deposed is virtually nothing. All right, let's see who won. Boys to Men won. They're too legit to quit. Hopefully somebody is rolling their eyes or at least laughing. You're all on mute, so I can't really tell, but that's definitely a dad joke. So that being said, we are at break. So it is 10:05. Let's have everybody come back at 10:15, and we'll hit the documentation stuff pretty quickly, and then we'll be done. So see you guys back at 10:15. All right, guys, I've got 10:15. Hopefully you guys are making your way back to a seat. But I'm going to go ahead and get started. So the next part of the lecture that we're going to talk about is documentation, or how we can hopefully avoid court together. Obviously, I don't have any disclosures, but also at the same time, I'm not here to provide you with legal advice. I'm not a lawyer. I am married to one, but that does not rub off on me. So we're going to talk about why we document, how we use it for QI, some of the billing criteria, and then also importantly, how we deal with refusals. So what is documentation? It can be electronic, paper, or some combination. For us, obviously, it's electronic. You know, we're using ESO. And as a result, it tracks any changes that we make to it, or any accesses. So if we need to go back and make an addendum or correct something, etc., after we have signed the chart, it's okay. We can do that. An officer can unlock the chart. It's going to log what was there originally, but it's also going to log then whatever you needed to add or to change as well. This is supposed to be an accurate record of what you did and what you saw when you were dealing with the patient. It's both a medical and a legal document. So yes, this is something that we use in healthcare, but it's also something that law enforcement may use, or it can be used in a civil case after the fact, you know, to document how a patient was acting, what injuries they had from an auto accident, etc. An important thing that you guys need to take away from today's lecture really is this: if you didn't document it, you didn't do it. That is as clear as I can get. If you didn't document it, you didn't do it. The lawyers in any case are going to eat you alive if you try and say that you actually did something but yet failed to document it, because that's cracked open a door that your documentation is not accurate, that your documentation is sloppy, etc. And trust me, you do not want to open that door unless absolutely necessary, because they're going to eat you alive. It allows them to ask you additional questions about the validity of it, your competence as a provider, you know, things like that. And so it really, really, really is important that if you do something, that you document that you did something. So who do we document on? Every time we interact with a patient. So that gets into, what is a patient? Well, it's complicated. I think that most of us would agree that the definition of a patient is, you know, somebody who either is asking for help, or a reasonable person would think needs help, that person is a patient. We are in the process of forming a subcommittee at the protocol committee to actually go over this very thing, because it has become a big enough of an issue locally, that we really feel like we need to see if we need to define this differently. But in general, it is better for us to document as if everybody we interact with is a patient than for us to not have documentation that we interacted with somebody. So there's this whole thing of injured versus non-injured. Somebody who is clearly injured, we can reasonably think that they're a patient, even if they're not the ones themselves asking for the care. But if somebody else, says, boy, this person is bleeding pretty badly from their head, it looks like they probably need help, and calls 911, then we probably ought to make contact with that person. Versus a bunch of people standing around a fender bender, etc., and you show up on scene and they go, no, none of us are hurt, we just need the police for the report, etc. Then, are those people patients? Well, not necessarily, but we probably should have some sort of documentation that we at least showed up on this emergency scene, verified that nobody was hurt, and cleared the scene. So not everybody that we see is necessarily a patient, but it sure is better for us to have some sort of documentation showing that we made contact with them. So again, if you didn't document it, you didn't do it. This documentation that you guys do really can set the stage for this person's care. It's a permanent part of their medical record. Not only do we at the hospital maintain it, but you guys as an agency have to maintain it. And it can contain some pretty crucial information. Just a few weeks ago, I had to work with a chief to get some documentation released about a cardiac arrest. The rhythm strips had never made it over to the chart, and so had to help facilitate getting the rhythm strips, etc., sent over so the hospital could have them. This documentation is also something that, I have previously used to justify getting somebody admitted. When we show up in EMS, our job is also to treat and stabilize. And so sometimes we do such a good job in EMS that by the time the patient gets to the hospital, they look like $1 million, because we have begun fixing their underlying problem. And so all their vital signs may look a heck of a lot better, and all their lab work may look a heck of a lot better than when EMS first showed up on scene. And so I've had to previously pull out the paramedics run report and show the other doctors, like, look, this is how sick this person was 20 minutes before they got to me. I know that they don't look that sick now, but it really was EMS who fixed that. So we need to talk about that more. Also, this documentation can be the determining factor in many lawsuits. Again, EMS in the state of Ohio really does have very good immunity, but we're not completely immune. And if we have, really good bulletproof documentation that spells out exactly what we did and didn't do, that can be a determining factor in many lawsuits, whether they even get brought. So there's some essential elements that have to be provided every time we document, and that's, date, run number, everybody that's involved in the care of that patient, all the demographic information, all the times, etc. It's also important that we get repeated sets of vital signs, that we accurately list the procedures and medications in the appropriate areas, that we get their past medical history, the medications that they're currently on, if it's pertinent to their care, and also, a narrative that spells out, what we saw, what we did, etc. There's some different methods of kind of organizing that narrative. A lot of you guys have been using the chart mnemonic lately, which I love. Chief complaint, history, assessment. R stands for treatments, and then transport. SOAP is one of the older ones: subjective, objective, assessment, and plan. Some people like to do chronological charting, where they will basically tell the story from start to finish. Everybody gets pounded into their head the sample history when we're in EMT: signs, symptoms, allergies, medications, past medical history, last oral intake, and then the events leading up to whatever happened today. As long as you're using some method of organizing your thoughts, it brings a lot of the clarity to the chaos when you're writing that narrative. When we deal with errors, EPCRs make this really easy because it's all logged. Any changes that we make after the initial document is signed are all going to be logged, and we don't really have to do a second thought about it. If, however, you're still someplace that's using paper, you're supposed to do a single line cross through with the initials and the date that you made it. You never use whiteout. You never try and falsify or destroy information. Trust me, it will come back and haunt you 10 times worse than whatever you're trying to destroy. Always, always, always complete your documentation as soon as possible. If you have missing documentation or your documentation is extremely late, that opens you to legal risk. Somebody who starts documenting 3 weeks after a run, if that run ever comes up in court, the lawyers are going to eat you alive because they're going to say that you're not accurately remembering, their client's run, and that you're making stuff up and falsifying it. And when you try and say, no, I clearly remember this, they're going to start asking you like, okay, if your memory is that good, what did you have for breakfast that morning? Okay, what about for lunch? What was the weather like on that day? And so they'll start asking you things like that to prove that you really don't remember things as well as you think you did. And so that can be just as bad as not having any documentation at all. There are some special circumstances with documentation, such as disasters and mass casualties. In those situations, we still have to have documentation. It may not be complete documentation, but we've got to have some sort of documentation about who we took care of, the rough estimates of what we did, that kind of thing. The juries in most of these cases, if these cases ever make it to court, have tended to give us a wide latitude in documenting, because they get that we're not going to have, the same ability to document that we do in normal circumstances. It's also really important that we document using some of these special alerts sections, and we're going to go over that, how we can use the software to better benefit us. And then it's also really, really important when you're talking to medical control that you document who you talk to, when you talk to, what the substance of that conversation was, etc. It's easy when you talk to me. You can just put, talk to Dr. Charlton. Here's what we discussed. Here are the orders he gave me. But when you're talking to a random doc at one of the facilities, it's really important that you know who it is that you're talking to, whether that be their ID number or their name, etc. So that way you can go back if that court or if that case ever comes up again, and you can say, no, it was Dr. So-and-so that did it, not just, well, I talked to a doctor at Bethesda North, because they're probably not going to be able to link that up with a specific doctor to then ask further questions of. And so that may leave you on the hook. So here's a couple of different special areas that are within ESO that you can use. Stroke is one of them. So this has the Cincinnati Pre-Hospital Stroke Scale, which is great. It shows when you performed it. You can document their last known well, whether the symptoms have resolved, when the patient thinks that the symptoms started. In this case, the patient must have noticed them at 6 o'clock in the morning, the same time as their last known well. Facial droop, arm drift, speech, and can allow you to document all this stuff. Same with the trauma criteria. This can allow you to go through and figure out, which of the things do I need to do and whether or not an activation is needed. And then if there is, what time I called and said that I'm activating a trauma alert, etc. So highly recommend that you open up these special flowcharts within ESO and use them for these special circumstances, because it provides proof that you were thinking that this person was a trauma or a stroke, and it prompts you for the necessary information that's needed to help treat that type of patient. So here's a really good, run. I'm not going to go through and make you guys read this entire thing, but basically this run is kind of going outside the norm. So this was one of my Georgetown runs where we had a patient that had been involved in a pretty bad trauma, and unfortunately the weather was not cooperating. So, the paramedic who documented this did a really good job of chronologically documenting, what they did, that they wanted to put the person in the back of a helicopter, but they couldn't because of weather. And so they made the decision to ground transport this patient from Georgetown all the way into University of Cincinnati, et cetera. And so this run report goes through and documents, all the stuff that they did, what the response was, what their logic behind the decisions they made were, et cetera. And so it was really a good way to handle it. We also use this to do quality assurance. Again, if you don't document it, it didn't happen. Please paint me a picture. Tell me how chaotic the scene was. Tell me, what the patient looked like. Tell me why you were making the decisions that you were. It's equally important to say why something couldn't be done. Before we started the lectures today, the 87s were asking about, what if we've got a patient who's refusing to let us do vital signs? Document that the patient refused to let you do vital signs. Document that they refused to let you do a physical exam. It's still important, though, in those situations to put down what you can see. So you still can do a physical exam without ever touching the patient. You can see what their work of breathing is like. You can see what their mentation is like. You can hear whether their speech is slurred, et cetera. So please document something so that it's there, but then document, that the patient was refusing to do things. Again, I really try and take the airline industry approach to chart review, which is, you take the assumption that it's pretty rare that a pilot gets behind the stick of an airplane and says, you know what, I'm going to crash this airplane today. Medical errors happen. It's part of what we do. Our job is to learn from those medical errors and hopefully engineer our way around them. I do not review charts with a punitive bent. To me, QA and chart review should not be a punitive process. They really should be a quality improvement thing. We should be looking at this to do, system-based approaches, such as, driving training, revealing issues. Do we need to look at how our drug box is laid out? Do we need to look at how we're doing training? Do we need to do different kind of training? Really look at this of how can I keep this error from happening again, and to treat everybody as if they're a pilot. So we do a random review of calls, but I also review every cardiac arrest, intubation, trauma. The refusals have gotten high enough at most of my agencies that I'm only doing a random review of the refusals as opposed to every refusal. OBGYNs, pediatrics, strokes, STEMIs. I'm also reviewing every narcotic or ketamine use and every restraint that we apply, because I think it's important that we have line of sight over, who we're restraining, how we're doing it, that kind of thing. So most of the time, there's no feedback to be given, and so the chart review just gets closed. Every now and then, I'll send you a message that says, good job, et cetera. If I've got a true concern, something where I'm really concerned about the clinical care, or I think that we need to discuss something, et cetera, trust me, guys, I am not going to hide behind ESO. I am not going to hide behind sending you an email, et cetera. If I have a real concern about something that you've done, we're going to sit down, we're going to have a cup of coffee and talk about it. Again, not as a punitive process, but as a, what do we need to do to change to keep this from happening again? Obviously, if the same problem keeps happening, time after time after time, that's different. Now we have, a pattern, but everybody is going to have a bad day. Everybody's going to have a bad run occasionally. It's okay as long as we learn from it and we grow from it. So anything that you guys get from me via ESO, or if it's an email, et cetera, please just take it as my random thoughts or an educational opportunity, et cetera, and not a criticism, not a pointing fingers, et cetera. It genuinely is not coming from that. It's supposed to be something that you would learn from, et cetera. But again, if I've got a problem from it, I'm going to be an adult about it. We're going to sit down, have a cup of coffee, talk about it, and I'm more going to be curious about what I can do as a medical director to help prevent whatever it was from happening again, whether it's training, equipment, etc. We also use the charts for billing, obviously, which helps with your budget. The better we document, the better we can bill, the better we bill, the more money that the city has to invest back into the fire department. Again, if you don't document it, it didn't happen. And so if you do a 12 lead EKG, document that you did a 12 lead EKG and what the outcome of that 12 lead EKG was. The mileage is crucial for the billing. Luckily, ESO makes that really easy. There are 4 levels of service that we can bill for, which is BLS, ALS1, ALS2, and SCT, which is specialty care transport, which includes mobile intensive care unit. Then there's also these emergency modifiers, rural point of pickup modifiers, which we won't get into, and then long travel distance, which again, we typically would not get into either. The nitty gritty of what we need to get into though is ALS1, BLS, and ALS2. So BLS is basically the default. We show up, we take care of the patient, we drop them back off. Great, that's a BLS. ALS1 is much more highly reimbursed than basic life support. You've got to have an advanced EMT or a paramedic on board who does an ALS assessment and provides an ALS intervention that's medically appropriate. You've got to document why you thought ALS care was needed, such as, with a chest pain patient, you've got to document that you did an ALS assessment, you did a 12 lead EKG, that kind of thing. ALS2 is basically the sickest of the sick patients, and it requires administration of 3 or more IV meds, either a bolus or a drip, and IV fluids don't count as one of those medications. So basically this comes down to, this is a cardiac arrest, or this is a really bad, trauma patient, etc., because it requires at least one procedure, whether it be defibrillation, intubation, a surgical airway, central venous catheter, pacing, IO, etc. And that pays 1.5 times ALS1. So it's really important when you're documenting on these super, super sick patients that you've got your procedures outlined where the procedures are supposed to go, that you've got your medications outlined where the medications are supposed to go. So that way you can get reimbursed appropriately for the level of care that you provided. There's also a thing called a paramedic intercept. Again, we don't really do that, so not as big of an issue for us. Refusals are one of the many reasons for why Dr. Charlton does not sleep well. It used to be the highest liability patient encounter that we had. It's now only one of the highest liability patient encounters. Lately, the highest liability encounters are civil rights violations, such as transporting somebody against their will or sedating them against their will, etc. Just because somebody signs a refusal does not mean that you're not responsible for that patient. We still have obligations to that patient, even if they are making a bad decision. And our obligation is really pretty simple. We've got to make sure that that patient, 1, can make decisions, and 2, can understand the impact of those decisions. And in order for them to make those decisions, we have to inform them of the risks of whatever decision it is that they're making. So it's not as simple as, we show up to, somebody's house and they say, I'm not going with you. I don't care what you say, etc. We have an obligation to tell them that, we're worried about X, Y, or Z, and this is the risk of what could happen if X, Y, or Z isn't dealt with. And then they're making an informed decision. So our job is to inform them of, kind of the risks and benefits of the various treatment options. We've got to describe why we're worried about it. And we've got to describe the risks of not receiving that care, which can include death, disability, loss of income, loss of consort, inability to work, etc. Even if you guys just put in death and disability, that's 90% of the way there. Most places that's going to be more than enough to document it appropriately. The simple presence of alcohol does not mean you can't refuse. If alcohol were the single determining factor, then anybody leaving Applebee's at 9 o'clock on a Saturday night would probably not be able to refuse care. Intoxication is what is different. So somebody that is intoxicated has an impaired ability to make decisions. That's not to say that they can't make decisions. It's to say that they're impaired. And so it should really give you pause and probably prompt a call to medical control. Altered mental status is the same kind of thing. It means that you can't comprehend or understand the risks associated with the decisions that you're making. Unless a minor is emancipated, a minor can't refuse care either. So at the very least, we need to get a verbal refusal from their guardian or their parent over the phone. I would recommend that when you have something like that occurring, just put them on speakerphone and have your partner on the truck also have the same discussion and document that, both of us heard mom say that, yes, we don't want little Johnny transported, etc. Patients that are on a psychiatric hold cannot refuse transport. So if the police decide to put somebody in custody because of a psychiatric issue, and the police say, we really want to transport with EMS, then, the police are the ones who get to decide how that patient is transported for the most part. So that patient can't say, no, I refuse to go in the ambulance. The police are the ones who can make that decision, as long as they're the ones who are maintaining custody of that patient and transporting with us. However, just because they're in the back of our truck doesn't mean that we get to, start an IV on them and, draw blood and that kind of thing. Patients are still allowed to make some autonomy decisions. And so if the patient says, I'm not going to let you guys take my vital signs, I'm not going to let you guys start an IV on me, etc., they're allowed to make that decision as long as it seems reasonable. Again, probably not a bad idea to get medical control involved. The courts tend to grant us pretty wide leeway on these, and so you're probably going to be fine no matter what. If you are getting a refusal, please try and get witnesses to sign. That can be the police that are on scene with you. That can be their family or friends, etc. So that way, you really are showing that this is not just Tom Charlton saying that they didn't want to go. This is Tom Charlton plus these witnesses saying that they didn't want to go. Sometimes we're going to get patients who refuse to sign anything that we put in front of them. That's okay. I mean, it's not like we can forcibly put the pen in their hand and make them sign, the tablet. Document. If the patient won't sign, that you've at least tried to explain to them the risks and benefits, that you've offered to take them to the hospital, they still are refusing to sign, etc. Just document. Don't forget to phone a friend. Medical control can sometimes help convince the patient to change their decision. At the very least, it's spreading that liability out, because now you've involved a higher level, and you can say, look, I was concerned enough about this patient that I even called the hospital, or I even called Dr. Charlton, and he had a conversation with them. And despite talking to the doctor, they still didn't want to go to the hospital. That's going to go a long way towards getting you out of the hot seat if that patient were to ever try and do anything about it later on. It's really important that we should never refuse to transport or assess a patient. If somebody calls 911, we should show up. We should offer to transport them, even if we think it's, a minor thing, etc., that doesn't need transport. EMS in the state of Ohio cannot refuse transport. We have an obligation to treat and assess people. And so, if the patient wants us to take them to the hospital because they have a hangnail or because they stubbed their toe, it's just better for everybody if we just simply suck it up and take them to the hospital. It's when you start to say, we're not going to take you, I refuse to take you, etc., that now you're really, really in the hot seat, and the patient's probably going to have a cause for action. We should never discourage transport. We should say, the hospital's really busy, or, if you go to the hospital, they're going to admit you to a nursing home, you probably shouldn't go, or, that's going to put you at risk of getting COVID, things like that. We never should be, discouraging transport, because again, that's not our role. Our role is, really, to to get that patient from point A to point B, with lots of advanced, specialty care that other places can't provide. We really shouldn't be making medical recommendations except to transport. One of the common things that I will use is, you were concerned enough about whatever this was to call 911. You probably ought to get that looked at by, a doc, to make sure that there's nothing else more serious going on. And usually that'll convince the patient, yeah, you're right. I was concerned enough about this to call 911. So maybe I should go get this looked at. So what we don't want is documentation like this, where, clearly we had a patient, but all the vital signs are empty. So it puts unable to obtain. And the default for ESO is if you don't put something in for a physical assessment, it defaults to not assessed. So what this reads is we showed up, we probably made contact with the patient, but we didn't get any vital signs and we didn't even look at them because we can't even tell what their skin was like or what their mental status was like, etc. So even if we put things in the narrative, this still is showing up as we did not assess them. And so again, that's going to be an area that an attorney is going to be able to crack open that case a little bit on, because they're going to say, look, you documented in one part that you didn't assess my client, but yet you say you assessed my client down in your narrative. So which part of the document have you falsified? Because that's the way they're going to try and present it. Even though we know and we can explain that, look, it defaults to not assessed if we don't put something in, that still opens up that door. And so at the very least, it's better to put in, look, the patient refused vital signs and the only physical assessment we could do was stuff that we could see from the doorway. That's fine. That's at least something. But it's definitely better than having a whole column of we didn't assess the patient, not assessed. So please, please, please fill something in. So here's a really good refusal. Okay. So we've got this, patient who we got back on his feet, etc. But we put in there, patient refused any assessment. Okay. They wouldn't let us feel around. They wouldn't let us get vital signs, etc. Patient refused any further evaluation or transport against EMS advice. We advised the patient the dangers of not being transported via ambulance to the ER. Patient continued to refuse. We read the refusal to them and they signed it. We then returned available. That's a really good refusal documentation because we're documenting why we didn't get a full set of vital signs or why, a full physical exam wasn't completed. We also documented that, we thought this person should go. We recommended a further evaluation. We recommended transport. We advised the patient the risks of that, and they still continued to refuse. So this is a really good set of documentation for a refusal. And if you look, it was 5 sentences. 5 sentences turn this into a pretty good refusal, assuming the rest of the documentation is up to snuff as well. So the big takeaway is if you don't document it, it didn't happen. You're never going to be able to remember this case 3 years from now when it goes to court. So document, 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 spend that extra couple of minutes to really tighten up your charting and your documentation. So that way on the off chance that you do get, a question about a case, all the documentation is there and nobody can open up, concerns about it. So. All right. With that being said, questions about anything that we've talked about?